In this video, we shall discuss in detail regarding the adverse effects of digoxin. Now, the adverse effects of digoxin may be conveniently discussed under three headings, namely cardiac, extracardiac, and electrolyte abnormalities associated with digoxin toxicity. Now, by far the most common and most dangerous adverse effects of digoxin are the cardiac arrhythmias. To have an idea about the arrhythmogenesis of digoxin, we need to have at least a rudimentary understanding about the normal action potential in a ventricular myocyte or in a His Purkinje fiber. Now, to begin with, we should know what an action potential is. An action potential is a graphical representation of the electrical activity in a single cardiac myocyte. This distinguishes it from the ECG, which is a graphical representation of the electrical activity in the heart as a whole. Right, so let's assume that this is one cardiac myocyte and this is another ventricular cell. The ventricular myocytes communicate with each other via gap junctions. Let us now draw the action potential of this particular ventricular myocyte. There's the y-axis on which we shall plot voltage, and there's the x-axis on which we shall plot time. The voltage of this cell at rest would be around minus 90 millivolts, and this is what we call the resting membrane potential. Any event that loads this particular ventricular myocyte with positive ions would make the voltage of this cell less negative. A voltage around minus 70 millivolts is considered significant and is called a threshold potential. And we shall see why this is so in the next few minutes. Right. So let us now trace the action potential of this cell at rest. As you can see, the blue line represents the voltage of the cell at rest. It's minus 90 millivolts, and this represents phase 4 of the action potential of the ventricular myocyte. Now, in this phase of the action potential, there are certain ion channels present on the surface of the cell. These ion channels are voltage sensitive. They are called voltage sensitive sodium channels. And in phase 4 of the action potential, these ion channels exist in the closed state. Now, being a ventricular myocyte, under normal physiological conditions, this ventricular myocyte cannot discharge impulses spontaneously. They need to be stimulated by impulses generated by the pacemaker of the heart, which happens to be the sinoatrial node in the right atrium. The sinoatrial node generates impulses which travel throughout the atrial musculature and ultimately reach the ventricles via the atrioventricular node. These impulses will ultimately reach this particular ventricular myocyte via the gap junctions. This current comes in the form of positive charges, and when that occurs, the voltage of this cell becomes less negative and approaches threshold potential around minus 70 millivolts. Now, once this occurs, the voltage sensitive sodium channel senses the change in voltage and changes its configuration from the closed state to the open state. Sodium ions rush into the cell, and as you can imagine, the voltage of the cell is going to change. It becomes less and less negative and in fact becomes positive. The voltage goes beyond 0 and well over to values of around plus 20. Now, this particular phase of the action potential is called phase 0 or the depolarization phase of the action potential. Now, within a fraction of a second, the voltage sensitive sodium channels will change its configuration from the open state to the inactivated state. Meanwhile, potassium channels open, allowing potassium to leave the cell. This causes the action potential to dip. And this phase of the action potential is referred to as phase 1 of the action potential. At the end of phase 1, the potassium channels remain open, allowing potassium to leave. But at the same time, voltage sensitive calcium channels open, allowing calcium ions to enter. The loss of potassium ions is more or less balanced out by the entry of calcium ions, and this results in a sort of plateau phase of the action potential. This phase of the action potential is what we refer to as phase 2 of the action potential, or the plateau phase. At the end of the plateau phase, the voltage sensitive calcium channels get inactivated while the potassium channels remain open, allowing potassium to leave, and as you can expect, the action potential will fall towards resting membrane potential, and this phase is what we call phase 3 of the action potential. We call it the repolarization phase of the action potential. So this is what we would expect to occur normally in the action potential of a ventricular myocyte, and this action potential is very similar to what we see in a His-Purkinje fiber. Right. So what would happen if we administered digoxin? What is the effect of digoxin on the action potential of a His-Purkinje fiber? Well, digoxin would have effects on both the duration of the action potential and the actual value of the resting membrane potential. Now, regarding the duration of the action potential, digoxin would initially cause a prolongation of the action potential, but this is transient. The overall effect of digoxin on the duration of the action potential would be to dramatically shorten the duration of the action potential. Now, a shorter action potential duration would mean a shorter refractory period, and if the refractory period is shortened, this will greatly predispose the patient to the development of all sorts of arrhythmias. Right. Now, regarding the resting membrane potential, now we know that digoxin works, or digoxin increases the intracellular levels of calcium, and this forms the basis of the positive ionotropic effect of digoxin. Now, in doing this, digoxin moves the resting membrane potential towards less negative values, or in other words, it makes the cardiac myocyte far more excitable. So if we were to look at the resting membrane potential here in this particular diagram, we can see that the administration of digoxin would raise the resting membrane potential, would make it less negative. Yeah. Now, if we were to trace the action potential after the administration of digoxin, you can see that phase 4 is not a flat line, it is more of a slope. Because of this shape of phase 4 and because the resting membrane potential is less negative, it is far easier for threshold potential to be reached after the administration of digoxin. As you can see, the duration of the action potential has been shortened as well. So this is how the action potential would look like after the administration of digoxin in a His-Purkinje fiber. Now, because phase 4 is so close to the threshold potential, the cell is highly excitable, and it may so happen that oscillating depolarizing currents may develop in phase 4 of the action potential after the administration of digoxin. Now, depolarizing oscillations in membrane potential that follow the preceding action potential are called after depolarizations. When they are seen in phase 3 of the preceding action potential, they are called early after depolarizations, and when they are seen in phase 4 of the preceding action potential, they are called delayed after depolarizations. Digoxin is associated with the development of delayed after depolarizations. So there is the delayed after depolarization that is formed after the administration of digoxin. Now, it may so happen that the delayed after depolarization may actually reach threshold potential, in which case a full action potential may actually form. Now this action potential has occurred not due to external stimulation by the SA node, but it has occurred spontaneously within the ventricular myocyte itself. So, after depolarizations can initiate impulse formation which are abnormal in the cardiac fibers, and this phenomenon is called triggered activity. So, a suprathreshold delayed after depolarization triggers abnormally timed action potentials, and these triggered activity can cause premature contractions. A premature contraction is also called an extrasystole or an ectopic beat, or simply a premature beat. Right. So, the effect of digoxin on the resting membrane potential would be to move it to less negative values, to produce delayed after depolarizations which, if they reach the threshold potential, can lead to triggered activity and cause extrasystoles or ectopic beats. So this was the effect of digoxin on the cardiac action potential. What would be the effect of digoxin on the ECG? Okay, so we need to understand that digoxin produces effects on the ECG both at therapeutic doses and at toxic doses. Okay, so now on the left hand side, on your left hand side, what you see is the action potential in a His-Purkinje fiber in the absence of digoxin. And on your right hand side, you are seeing the black tracing which represents the action potential after the administration of digoxin. So those are action potentials. The corresponding ECG tracings would look like this. So the ECG tracing on your left hand side now corresponds to the normal electrical activity in a His-Purkinje fiber. Now the double-headed arrow that you see represents something called the QT interval. The QT interval corresponds to the beginning of the QRS complex to the end of the T wave. Now, if you look at the corresponding ECG after the administration of digoxin, you can see two important changes here. The first is in the length of the QT interval. As you can see, the length of the QT interval has considerably shortened. Also, there are changes in the ST segment and in the T wave. The changes in the ST segment and the T wave are collectively called the reverse tick sign. And from the animation, I hope you will be able to appreciate why. The reverse tick sign is also called the scooping sign. Right. So, as discussed, the QT interval is defined as the part of the ECG that corresponds from the beginning of the Q wave to the end of the T wave. It signifies the length of ventricular action potential, and obviously after the administration of digoxin, it is considerably shortened. The ST segment extends from the end of the QRS complex to the beginning of the T wave, and it corresponds to the plateau phase of the action potential. Now the changes in the ST segment and the T wave are together called the reverse tick sign or scooping sign. So these effects which occur at normal therapeutic doses of digoxin are together called the digitalis effect. So the digitalis effect can be seen at normal therapeutic doses of digoxin. Toxic doses of digoxin are not required to produce the digitalis effect. Now, in addition to these two effects, there is yet another effect that occurs even at normal therapeutic doses of digoxin, but by convention it is not included under the term digitalis effect, and this is a prolonged PR interval. The PR interval may be defined as the part of the ECG that corresponds from the beginning of the P wave to the beginning of the QRS complex. It signifies the onset of depolarization of the sinoatrial node to the depolarization of the ventricles. We know that the cardiac glycosides like digoxin have got a vagomimetic effect on the AV node, and therefore we can correctly presume that the PR interval would be prolonged after the administration of digoxin. So, the effects of digoxin on the ECG, even at therapeutic doses, would include the digitalis effect, which would include changes such as a shortened QT interval and scooping sign or reverse tick sign, as well as other changes such as a prolonged PR interval. So these are the changes that we would expect in the ECG even after a normal therapeutic dose of digoxin. What would happen if digoxin toxicity were to occur? What would we find in the ECG? Right. So toxic doses of digoxin lead to electrical events in the ECG known as premature ventricular contractions or PVCs. A PVC is characterized by the premature occurrence of a QRS complex. In other words, a PVC is an abnormally timed QRS complex. As digoxin toxicity becomes more and more, the ECG begins to show distinct patterns. The patterns are given various terms. They include trigeminy, bigeminy, couplets, triplets, and ultimately ventricular tachycardia and ventricular fibrillation. Now, when there is ventricular trigeminy, what we mean is that a premature complex follows two normal beats. So you can have a normal QRS complex and then another normal QRS complex followed by a PVC, and then normal QRS complex, PVC. That's what we mean by a ventricular trigeminy. On the other hand, a bigeminy would mean a normal QRS complex and then a PVC, normal QRS complex, PVC, and so on. So every alternate beat would be a PVC. Now in the case of a couplet, as you can imagine, it would mean a normal QRS followed by two PVCs and then a normal QRS, two PVCs, and so on. A triplet would mean a normal QRS complex followed by three PVCs and then a normal QRS complex again, three PVCs. And anything more than that would be a ventricular tachycardia, which could immediately degenerate into a ventricular fibrillation, which is quite life-threatening. So as digoxin toxicity progresses, the patterns of premature ventricular contractions evolve in this particular manner. Right. Okay. So, the adverse effects of digoxin may be cardiac, extracardiac, or specific electrolyte abnormalities. When we talk about the cardiac abnormalities, we can talk in terms of the action potential or the ECG. In terms of the action potential, toxic effects of digoxin include the formation of delayed after depolarizations that can cause ectopic beats or extrasystoles. In the case of the ECG, we will find premature ventricular contractions that may present themselves in various patterns, like for example a trigeminy, bigeminy, couplets, triplets, or indeed ventricular tachycardia or fibrillation. In truth, digoxin toxicity can present with almost any type of arrhythmia. Of course, the most common form of arrhythmia would be the formation of premature ventricular contractions in various patterns, but the most characteristic arrhythmia associated with digoxin toxicity would be atrial tachycardia with variable degree of heart block. Okay. So now we move on to the extracardiac effects, extracardiac manifestations of digoxin toxicity. These are different in acute and chronic digoxin toxicity. In acute digoxin toxicity, the first symptom is typically nausea, vomiting, and abdominal pain. In chronic toxicity, however, the symptoms are a little different. GI symptoms do present themselves, but together with these, neuropsychiatric symptoms and visual aberrations may also appear. Neuropsychiatric symptoms such as delirium, hallucinations, and occasionally even seizures. Peculiar visual aberrations may develop, including scotoma and yellow halos around lights, which we call xanthopsia or chromatopsia. Other rare adverse effects of digoxin include gynecomastia in males. Okay. Now finally, regarding the specific electrolyte abnormalities in digoxin toxicity. Now, we need to understand that in general, chronic toxicity with digoxin leads to hypokalemia. This is not difficult to imagine. Digoxin is normally administered in chronic heart failure, and such patients are commonly prescribed potassium wasting diuretics. Digoxin also has got an indirect diuretic effect and can cause increased loss of potassium in the urine as well. So chronic toxicity with digoxin is more commonly associated with hypokalemia. On the other hand, acute digoxin toxicity, for example an overdose of digoxin toxicity, is more likely to present with hyperkalemia. Now, when we talk about the management of digoxin, the serum potassium levels have a central role to play. It's important to measure the serum potassium in any patient with suspected digoxin toxicity. The reason is that hyperkalemia can exacerbate digoxin toxicity, and hypokalemia can also exacerbate digoxin toxicity. We need to also remember that the definitive therapy for life-threatening digoxin toxicity is the administration of digoxin-specific antibody fragments. It causes a sharp decrease in the free serum digoxin concentrations, and it also causes a sharp decline in serum potassium concentrations, so much so that it could actually cause hypokalemia. So, when digoxin toxicity is suspected, it would be prudent to measure the serum potassium, and if the patient is found to have hypokalemia, it's probably a better idea to correct the hypokalemia first without overcorrection and making sure that the patient doesn't go into hyperkalemia. Now, if the serum potassium levels have been corrected and in spite of this the patient still shows symptoms of digoxin toxicity, then probably at this time it would be a better idea to start administering digoxin specific antibody fragments. On the other hand, if the patient was found to have hyperkalemia, especially if the serum potassium is anything above 5 milliequivalents per liter, then it's probably a better idea not to hesitate and promptly begin digoxin-specific antibody fragments. If this is not available, or in the unfortunate situation where this is prohibitively costly, then the serum potassium should be lowered rapidly by the administration of IV insulin, dextrose, sodium bicarbonate, and potassium binding resins. Okay, so there is a rationale of administering potassium to a patient with digoxin toxicity and hypokalemia. Well, there are 3 reasons for this. The first reason is obvious. Hypokalemia exacerbates digoxin toxicity, so it makes sense to normalize the serum potassium. Secondly, we did see the structure of the sodium-potassium ATPase pump in detail in the previous videos. We saw that it pumps 3 sodium ions out of the cell and 2 potassium ions into the cell. We discussed that the alpha subunit of the sodium-potassium ATPase pump is attached to a beta-aspartate moiety. We also discussed that digoxin binds to the extracellular component of the sodium-potassium ATPase pump. Now, digoxin binds much more strongly to its binding site when the beta-aspartate moiety is in the phosphorylated state. if we were to increase the extracellular concentrations of potassium, it would lead to dephosphorylation of the beta-aspartate moiety and cause digoxin to bind much less strongly to the sodium-potassium ATPase pump. So this may also explain why increasing serum potassium levels may reduce the toxicity associated with digoxin. And thirdly, potassium also competitively inhibits digoxin at the sodium ATPase pump. Now, having said all of this, it is important to understand that hyperkalemia itself is dangerous and can predispose to life-threatening cardiac arrhythmias by itself or in association with digoxin toxicity. Therefore, the aim is to maintain normal serum potassium levels without over or under correction. Okay. Now, other measures that can be adopted in acute digoxin toxicity include the administration of activated charcoal, the administration of atropine to overcome heart block, and the administration of antiarrhythmic drugs, notably phenytoin and lidocaine. Now, phenytoin may terminate supraventricular tachyarrhythmias associated with digoxin better than lidocaine. However, lidocaine is more effective in terminating the ventricular arrhythmias associated with digoxin. Again, having said all this, the digoxin-specific antibody fragments are by far the drugs of choice, and if available and if feasible, they are preferred to the administration of either phenytoin or lidocaine for life-threatening arrhythmias associated with digoxin. Finally, to conclude, DC cardioversion is probably not a good idea in many cases of digoxin toxicity. It's a hazardous affair. It can lead to asystole and ventricular fibrillation and is probably best avoided in most cases of digoxin toxicity.